Wonderful. Well, thank you all for being here. I'm Joan Stauffer. I'm Product Marketing Director at Iridex. And it's my pleasure to introduce our next speaker for the day, Dr. Margaret Wong from Eye Consultants from Atlanta. She's been using MicroPulse for about 2 years, and she's here to share her experiences of expanding treatment options using MicroPulse for chronic macular edema. Thank you for being here. Podium is all yours.
Okay, thank you so much for coming here this afternoon. Can everybody hear me? Okay, all right. So as Joan said, I work at Eye Consultants of Atlanta. I'm a surgical retina and uveitis specialist with Eye Consultants. I've been there for 3 years. We've been using MicroPulse, me and my partners have been, for about 2 years, and I just wanted to share some of my real world experiences with MicroPulse. So first of all, what is MicroPulse? It's a method of using continuous wave beam, but cutting it into short, repetitive pulses so that it doesn't do damage to the retina. And the reason that we have incorporated MicroPulse and bought the machine is because we have a lot of patients who have macular edema, secondary to diabetes, uveitis, and retinal vein occlusions, and the macular edema happens to be very close to the foveal center or right underneath the fovea. And it's been inaccessible to us for treatment based on traditional focal laser. And it's always a problem when patients do not respond to our steroids or anti-VEGF injections. So these are the undertreated population that we're talking about today as well. So again, MicroPulse is a great treatment option for people who cannot tolerate injections, who refuse injections. I mean, we all have patients that come in and say, there's no way that anybody's touching my eye with a needle. And for steroid responders, which is a big problem in my uveitic population, so some of those patients don't even respond, or don't even tolerate Durezol for their treatment, and let alone a intravitreal triessence or Iridex. And it's also a good alternative for patients who have had a stroke, and there's been evidence, kind of inconclusive, that link the anti-VEGF agents to stroke. So, I don't want to impose more harm on the patient, so we stop the injections, but what do we do? Well, we can incorporate MicroPulse into our regimen. And so what do we consider patients to be when do we consider patients to be non-responders? Well, if patients have on OCT continued fluid, so persistent fluid after 4 to 6 anti-VEGF injections, or who have not been responsive to 2 to 3 intravitreal steroid injections, I consider those people to be non-responders. And so we're looking at an alternative way to treat those patients. So, honestly, I don't usually use MicroPulse as a single method of treatment. I usually use it as an adjunctive treatment to my anti-VEGF and intravitreal steroid therapy. But the good thing about incorporating MicroPulse is that I've had to inject less anti-VEGF injections per patient, and they've actually been responsive to the treatments better, and it's also a longer duration of success before recurrence of the macular edema. And all of these things result in a better quality of life for each patient. So previously, there were no real good options for patients who had macular edema that were close to the foveal center or involving the fovea. And so using the MicroPulse really complements the treatment methods that we've been using, like anti-VEGFs and steroids. And it's reduced a lot of the treatment burden that we've had to do for patients. And so because of MicroPulse, we've increased our laser usage by about 25%. And of course, that's associated with higher revenue for us because it pays much better than just the injections alone. So when I first started using MicroPulse, I wasn't really comfortable with lasering the fovea. Because we've always been trained not to stay far away from the fovea as we can, not to disrupt the center. So in the beginning, I was only doing 200 to 300 spots, and I wasn't really going over the fovea. But I learned later on that I have much better success rates when I use more than 500, or at least 500 spots, and that it can be placed safely on the fovea. So that was kind of the learning curve. And is it safe to treat the fovea? Yes, it is. I was a little surprised, but after that, it was, I went over the fovea on everybody with comfort. And the patients didn't feel it. There's no scarring. You can't tell even right afterwards that you've inflicted any damage on the fovea, which is great. And if I use laser by itself, I see results at about 6 to 8 weeks after treatment. And if it's an adjunctive therapy to anti-VEGF or steroids, at about 3 to 4 weeks or so. And it's very easy to use. It was like using focal laser, the traditional focal laser. It just attaches onto the slit lamp, any of the slit lamps that we have. And the only sticking point with me was the treatment of the fovea. But after that was, after going over that in my head, and I was comfortable with it, I was comfortable performing 500 to 700 spots, which worked a lot better. So just a couple of case examples. I had a patient that was a 61-year-old white man with diabetic macular edema. He had chronic persistent CSME, and his vision was 20/20 in the right eye and 2400 in the left eye. So the prior treatment methods that I was using was traditional focal laser in both eyes, and every 4 to 6 weeks Lucentis injections in between the focal lasers. We even used the intravitreal triescence in his left eye. However, his vision in the left eye improved to 2200, and that's where it sat for 2 years. And as you can see, even though he was 20/20, unbelievably in the right eye, he had a lot of macular edema on the OCTs. And that was persistent. In November of 2014, we started using MicroPulse, and we performed 2 MicroPulse treatments in the right eye and 3 MicroPulse treatments over in the left eye. And he still did receive his Lucentis treatments. However, after 2 years, his vision in the left eye improved to 2100. And even though it only improved by 1 line, subjectively, he felt like there was a lot of significant improvement. And he and I are both very big fans of the MicroPulse laser. I have a lot of uveitis patients, and a lot of them have a history of steroid response, as was the case with this 50-year-old female. She had uveitis, chronic, long-term uveitis, and cystoid macular edema. Her vision was count fingers in the right eye because of end-stage uveitis hypotony and 20/50 in the left eye. She had the cystoid macular edema that was really bugging her, and it was her only eye that was the problem. She had partial response to Avastin for the CME. Her vision improved to 20/40. However, after a single MicroPulse treatment, she had complete resolution of her CME on OCT, and she has been great ever since. I actually just saw her about 4 weeks ago, and her OCT remains perfect. So, the takeaway from some of these patients is, for the uveitis patient, it seemed to work as a single treatment method. For DME, I find that it works a little better as an adjunctive treatment. So in a nutshell, I feel like MicroPulse is a gentler way of performing laser. It definitely adds a lot of benefit to my practice, and it's a very versatile treatment option. It reduces pharmacotherapy for patients, and that all of this increases my usage of the laser, and also the patients also ask for it as well. Patients say that they prefer this treatment. Now, a lot of my patients have had traditional laser and also MicroPulse, and some of my patients say that it's more comfortable to get the MicroPulse. It is a lot of bright lights and everything, and patients still say that, but they say it feels better, and they know that it's a better treatment for them because it doesn't do any damage to the fovea. We've also extended it as a marketing tool, so patients know that we're one of the only centers that have this laser, and so that's been good for influx of self-referrals to our practice, because they see that we're the only ones that use this, and we've been using it for a couple of years now. So it has increased our laser revenue and the revenue overall. So also, this gives you just another treatment option for patients that would otherwise not be treated or undertreated, and their diseases have not responded to the current treatments. Gives you another modality for treatment. Just makes you a more versatile physician. And also, it's very safe to treat the fovea. Some take-home points. So there's longer duration between recurrences, and it's more sustainable vision. These patients, the vision gets better, and it stabilizes that way. And it's an alternate treatment for people who can't undergo the current pharmacotherapy that's out there. And it's a really good option for patients. Increases their quality of life. And at the end, I would say you have better and happier patients, and they appreciate you much more. So that's it for my talk. Thank you.
Very much. Thank you. Are there any questions or comments? Yes. If you can put your headset on and then, okay. Can you hear me through your headset now? Okay.
Excuse my English. Okay. What's the protocol, your protocol? If you injection everything, how many days you can to do the MicroPulse? How much time is you take? 1 or 2? You understand me?
Yeah, so
Yeah.
you're saying what is the lag time between an injection of, say, Avastin or
Yes.
Lucentis
Yes.
and then the performance of a laser treatment? I usually wait about 4 weeks, but I don't think that there's any time lag that needs to happen. I've done a laser treatment and then an injection of an anti-VEGF agent shortly after that. I would say a week later. Probably the closest, but I don't think there's any lag time that needs to happen between injection and a laser.
I used to do 1 week after. 1 week.
I'm sorry?
One week, I make the MicroPulse.
Uh-huh.
In Macular Edema. It's not safe.
I'm sorry.
1 week after.
Oh, 1 week
injection,
after?
1
Yeah,
week.
it's safe.
Safe.
Yeah, it's safe. It's
Okay.
safe to do that. Sometimes I even do laser and injection on the same day.
I used to buy microscope. Then I do the laser, MicroPulse. I look for the retina. After 15 days after, I look again. If you had edema,
Okay.
I repeat.
Oh,
It's
okay.
safe?
Yeah, I think it's safe too. Yeah,
you.
absolutely. Sure.
Hi.
Hi.
If you don't have a good response in the first MicroPulse
Okay.
section,
Uh-huh.
how many times and how long you wait for the next time?
I usually wait about 3 months. I have patients that respond in 6 to 8 weeks after the laser. However, I give it 3 months just to give it the full time for the retina to respond to the MicroPulse, and then I would repeat it again in 3 months.
3 months.
Yeah,
You don't
in
do
about 3 months.
before 3 months.
I don't. You could. Also, billing becomes difficult at that point also. But I think that, I wait 3 months to give it the full time for it to take effect.
I have to use sometimes the MicroPulse. In some case, I don't have good response.
Yeah, sometimes that happens to me too. But that's why I use adjunctive treatment like the anti-VEGFs or an intravitreal steroid.
Have you been used with Iridex too?
I haven't combined it with Iridex. I've combined it with Triessence mostly,
With Iridex, no.
but not Iridex. No.
Okay.
I do use Iridex, but alone by itself.
Hello.
Hello.
What are your parameters and the aim point of your laser?
Okay. I use the preset settings on the MicroPulse. And I've been told not to mess with the settings because if you increase the energy, it might be a little bit too much energy delivery to the retina. So I haven't touched the preset settings. If I want a little bit more treatment, if the patient has a little bit more macular edema than the next patient, I increase the number of spots that I use. So I titrate it. I go between 500 to about 800. The highest I've gone is 800. And even at 800 spots, I don't see any damage afterwards to the retina. And we've got good follow-up for those patients. at least a year on all those patients.
So you're using a 5% duty cycle,
5%.
200 micron spot size,
Yes,
200 milliwatt duration, and 400 milliwatt
400. Yep.
power.
Milliwatt power.
And that's with the 577 laser.
Yeah.
Is there an optimal size for the grid? Because the sales rep told us that it's better to make it compact or more confluent, the laser. What do you think?
Well, I base it on the fluorescein angiogram. I look at the leakage pattern, and I try to cover all of the leakage patterns and the microaneurysms, if there are any. Frequently when I do MicroPulse, it's because there aren't any leaking microaneurysms, and then I guide myself with the OCT. I try to cover as much of the edema as I possibly can. Oh, you mean the grid?
The actual
pattern.
grid, because you can make it smaller, big, to make that laser tighter.
Oh, yeah.
It's the confluent. How confluent are the spots that you deliver?
Oh, okay. I don't actually make that any different on any patient. Yeah, it's whatever the preset settings are.
Okay.
Yeah.
You're talking about the textile, the pattern scanning, right? Correct. Zero spot spacing, confluent delivery.
Hey, Dr. Wong, how many
Yeah.
times have you retreated a patient over, if you have somebody with refractory edema that you've injected and they've gone from 2100 down to 2050, 2060, and they kind of stagnated, and you laser today, wait 3 months, you laser again in 3 months? I mean, how many lasers over a time have you treated with a patient? Or if they come back in and you see the swelling starting to creep back up, have you lasered again instead of doing an injection?
I have lasered again, and it's mostly for patients that won't tolerate injections for whatever reason. Maybe they had a stroke, or maybe they're a steroid responder or something like that. And it's been really good. I did a patient 3 times in a year, and it's held off on the macular edema. It gets worse sometimes, but then we'll retreat and it'll get better. But I feel like you're decreasing the patient's risk to endophthalmitis, retinal detachments from the injections that they would have gotten. So it's a really great trade-off for my practice. So I don't have to worry about those things. It lets me sleep at night a little bit better,
Nice.
Yeah.
Nice. Thank you. Any other comments, questions? Okay, well, thank you very much.
Okay, thank you so much for
you.
your time.